Okay. Thank you, everybody. This is the last installment of our series of 6 lectures. This was actually supposed to be the 5th one. We started off with the last one, if that makes any sense whatsoever. But this is what I'm going to cover today is diagnostic test evaluation. I really like this topic. It's actually been a few years since I've lectured this topic, but I do remember enjoying it quite a bit, when I was going through my notes. Okay, so just as a preamble, and I really don't want to go into the nitty-gritty of differences between diagnostic tests and screening tests and stuff like that, because the way I'm going to cover it, it doesn't really matter too much. But I sort of will mention it briefly. So a diagnostic test represents a tool where patients, I don't know why I wrote whereby there, where patients are tested for the presence or the absence of a disease. They can be used in a range of applications ranging from screening, surveillance, or confirmation. Now, mainly today, I'm going to sort of talk about the more confirmatory ones. But typically speaking, a diagnostic test is used to confirm the absence or presence of a disease where we suspect the disease is present. So a patient might present with symptoms. We think that they may or may not have a particular disease, and we'll run a diagnostic test on them. Whereas a screening test is for asymptomatic individuals. So we do it on a large scale to detect things. Okay, now I guess the only reason I'm mentioning these 2 types of applications is the relative importance of getting it wrong might change across these 2 settings. So how sensitive a test is as opposed to how specific it is might actually change that. And if you don't know what I mean by sensitive and specific, I guess stay tuned. So today we're going to consider methods, I should really say statistics, not methods, that actually evaluate a new diagnostic test against a gold standard. That's going to be the thing I concentrate today, as opposed to comparing different diagnostic tests, okay? Now, very important word or term here is gold standard, because people are a little bit rough and ready with their definition of it. And I do want to talk a little bit about that. Okay, so where we're going to go, I'm just going to continue introducing the topic, and then we're going to talk about different measures of diagnostic accuracy. Now, the problem with the word term diagnostic accuracy is it's very vague, and the word accuracy is thrown around a lot when it comes to diagnostic tests. So specifically, it means 2 different things. It's a general term to tell us about how close the diagnostic test is to reality across the board, but it also refers to a specific statistic for measuring how good a test is, okay? So you can see diagnostic effectiveness, I've got in brackets accuracy, because people will often use that word specifically to talk about this aspect of diagnostic accuracy. And if you're confused already, that's because it's very ambiguous that the word accuracy is used in 2 contexts here. So I'm going to talk about diagnostic effectiveness, sensitivity and specificity, sometimes just called sense and spec. And I'm then going to go on to predictive values, likelihood ratios, and then I'll talk about ROC curves. I'll briefly mention a couple of other measures, Yoden's index and the diagnostic odds ratios. Really, all of these different things are just to tell us, is it good or is it not good, our proposed diagnostic test. Then we'll go through a case study where we'll consider febrile children and how we might diagnose them. And then I'll talk briefly about reporting. I'm also going to talk about sample size. Now, I'm not going to go into a lot of detail about it. I really just want to give you the formulas because I did go through sample size in the first lecture, and I just don't want to go through the nitty-gritty of it because it actually takes quite a bit of time. But I do want to give you those formulas. Okay, and then briefly, I want to put it into the context of clinical epidemiology right at the end. And I was saying before too that I really like this topic because yes, it's biostatistics, it's clinical biostatistics, but it's very much contextualized in terms of solving a particular clinical problem. So it emphasizes clinical epidemiology much more. And I really like talking about clinical epidemiology as opposed to biostatistics. I love biostatistics, I just realize other people don't. So that's why I like talking about clinical epidemiology. It's so nice and practical. Okay, so let's get to it. We will consider the situation where we want to compare a new method for diagnosing disease. And remember, here we are just talking about a disease being present or absent. So we're sort of using our new method to guess or say whether it is there or not. How will we work out whether our guess is good? We will compare it against a gold standard. Now, I want to make a very, very important point here because I see this mistake by people. If we look at this, it looks like a reliability analysis. In other words, about agreement, sort of like inter-rater agreement, where one person says yes, and we want to see whether another person says yes. That is not what diagnostic test evaluation is, because both of those raters, both of those people might get it wrong, okay? So there's a very important difference we have to, that I really need to underline here, and that is that a gold standard is a true, shiny gold standard. It is 100% the truth. It's not the best method we have at hand. It must be the truth. And the reason is because if our new novel diagnostic test does not agree, we must assume that the error is with the new test, that the gold standard is 100% correct, not 99% correct, because if our new diagnostic test says no and the gold standard says yes, we must assume that the diagnostic test got it wrong and that the gold standard is 100% correct. So the reason I want to underline that is I see people all of the time just get something that has been seen as 98% sensitive and 97% specific, and they say, I'm going to use this as a gold standard. If you don't have a gold standard, you can't just say something that's not a gold standard is a gold standard. It's not. Then you would have to just say, you'd have to talk about agreement with the best method available. Okay. I just want to make that because it's extremely important that a gold standard, we just have to remember where the term gold standard comes from, where it was a set weight, I think, in Britain for a piece of gold, and everything was compared to that. I think that's where it comes from, something like that. Yeah, okay. Okay, so let's start by talking about the elements and really how we calculate all of these different statistics. So let's look at a diagnostic test table. The first thing we should notice is that we have the truth, according to our gold standard over here, the actual disease status, whether you have the disease, D+, or whether you don't. Now that's truth. The diagnostic test, our novel diagnostic test, will say you have the disease, or it will say you will not have the disease. We don't know whether that's true or not, and that's the whole purpose of diagnostic test evaluation, okay? So just note these quantities here because I will come back to them, okay? Now just note this green part here, we get it right. We say you've got the disease and you truly have the disease. Another term for that is true positive. The other green, or the other time we get it right, is when we say the disease is absent and it truly is absent. That is a true negative. Here, where you've got the disease, but our diagnostic test misses it, it's called a false negative. And conversely, when you don't have the disease, but our diagnostic test says you have it, that's called a false positive. And they're very, you know, when you think about their names, they're very sensible. Okay, so just note the green here is where we get it right. The red here is where we get it wrong. And these two different types of reds often aren't of equal importance. Sometimes a false negative is much more important than a false positive, and sometimes it's the other way around. Okay, so let's now talk about the test accuracy, or sometimes called diagnostic effectiveness, which is probably a better name for it because the word accuracy is so ambiguous here. It is simply the greens, so true positives plus true negatives, over everybody. And really, what is it? It's the proportion of people out of our sample we got right, whether they're positives or negatives. It's as simple as that. So we may say that 80% of the people we got it right, whether they were positives or negatives, where 20% we didn't. So it could be presented as a proportion, as it is here, or a percentage. Nice and simple, okay? It's really just the sum of people in this main diagonal over everybody. All right. The next ones, and very closely related to this, are the sensitivity and the specificity. So the sensitivity we assume to be the probability based on our sample that the test correctly classifies somebody with the disease. In other words, the probability of getting a positive test given you've got the disease. Specificity is the probability that the test correctly classifies a non-diseased patient. So the probability that you get a negative test result given you don't have the disease. So sensitivity and specificity tell us how well a diagnostic test discriminates between patients with and without the disease. And just note this probability notation here, that probability A dash B means the probability of event A given or conditional on event B. So the probability of T plus line D plus implies the probability of a positive test given you truly have the disease. Okay, so let's just go through a very quick example. And really, these are sort of things you can just do by hand. They're so very simple and intuitive too. At least these earlier statistics I'm going to talk about. Okay, so here we have 100 people with the disease and 1,000 people without the disease. So that's the total in that row, and that's the total in that row. So 100 people truly had the disease and 1,000 people truly didn't. Now, our sensitivity is the true positives over everybody who had the disease. So we correctly classified 90 people with the disease, 90 people, we said 90 people had the disease who truly had the disease. So in this case, our sensitivity is 90% or 0.9, okay? The specificity is the number of people we said who were negative who were really negative. So we got 80% of people who truly didn't have the disease, we identified as not having the disease. Now that's quite simple really, okay? It's quite simple to work this out. You can actually just, I mean, in this case, because the numbers are so nice and round, you could just do it in your head. It's very, very simple. Okay, and by the way, a test, depending on context, but a test that has 90% sensitivity and 80% specificity is generally a pretty good one, okay? Okay, so we can see we've got 90% sensitivity and 80% specificity. And just digging a little bit deeper, for every 1,000 disease patients, we will miss 100. So this is about the cost of having a lower or higher sensitivity and the cost of having a higher and lower specificity. And we really do need to think about it because it does change over various applications. I mean, how bad is it to miss a test? How invasive is the test? Those sorts of things. We really do need to consider that. So for every 1,000 people who have the disease, we miss 100, okay? And if we're talking about something like cancer, where if we don't catch it in time, the prognosis for the patient really gets much, much, much worse. That's not very good at all, Okay. Now, thinking about it from the other way, for every 1,000 non-disease patients, we will accidentally classify 200 with the disease. So we have to think about the cost of telling a patient they have the disease when they really don't. Okay. Now, in some context, if I say to someone, you've got the flu when you really don't, that's not a big deal. But if I tell you you've got cancer when you really don't, that's horrible. That's horrible for the patient to go through. I shouldn't say patient, for the person to go through. However, we also need to admit that these things are sort of mutually exclusive, that as sensitivity goes up, specificity will go down. Okay, so we do have a choice, and I'll talk more about that later. Okay, so there's also something else we have to consider. Now, this is not something that affects sensitivity or specificity themselves, but it is something in terms of, I guess, the cost of getting it wrong, and that is what is the prevalence of the disease. How common is the disease itself? Okay, so I just want to give you some examples here, and then I'll sort of stop talking about this. Let's consider a case where the sensitivity is 90% and specificity is 80%, just like we just calculated. And in all three cases, we're considering 10,000 patients. And I shouldn't really say 10,000 patients, 10,000 people, because if you don't have the disease, you're sort of not really a patient. Okay, so in the first case, we're talking about hypertension in elderly males. The prevalence is 50%, okay? By the way, I'm just making this up. Here, 5,000 men who have hypertension, 4,500 will be correctly classified. So if you've got hypertension, we've got a 90% chance of actually detecting you. 500 are going to be missed. They're going to be sort of sent home, and we're going to not know they have hypertension. They're not going to know they have hypertension. And of the 5,000 without hypertension, 1,000 will be falsely diagnosed as hypertension, which is probably not the worst thing in the world in this case. Being told you have hypertension when you really don't. I mean, there are worse things that can happen to you. Okay, now let's go to recurrent breast cancer, which has a prevalence of 10%. Again, I'm just making this up. Of 1,000 women who have recurrent, so remember, we have 10,000 people overall. Of the 1,000 women who we say, who truly do have recurrent breast cancer, 100 will be missed. And if we missed, they're probably, they could die. They could die from this. Of the 9,000 who don't have the disease, 1,800 women will be told falsely that their cancer has recurred. Now, that also has a very high cost, because we're telling a woman they have recurrent breast cancer when they really don't. Okay? The last one, screening for colorectal cancer, we have a prevalence of 1%. Now, notice here, this is a screening situation, and it's quite rare in the people we are administering the test to. And by the way, I'm just saying 1%. Again, I'm just making this up. Of the 100 people, out of our 10,000 people who truly have colorectal cancer, 10 will be missed. Okay? We're going to just say, no, you're fine, don't worry about it. Of the 9,900 who don't have colorectal cancer, 1,980 will be told that they have colorectal cancer. We would probably then go and send them for, a much more invasive confirmatory test. So that's the cost in this context. So I guess here, sensitivity and specificity doesn't change with prevalence, but its cost or its burden may actually change across different settings. So we want to actually take that into account. Okay, so now we've talked about sensitivity and specificity, which are probably the most common statistics that I quoted, and they're usually the most important ones. Not always, but they're very often the most important measures. Okay, but let's talk about some other measures, and I'm going to talk about predictive values. And predictive values tell us a little bit more of the utility or usefulness of a test. Okay, so there is a positive test version and a negative test version. So it's called positive predictive value, which is sometimes called PPV or PV with a little plus sign, and a negative test version, which will be PV with a little negative sign, or just called NPV. And these things are often referred to as posterior probabilities for a very good reason, which I'll go into soon. Okay, so what are they? The positive predictive value represents the probability of having the disease given you have a positive test result. So here we have switched around these probabilities. So what it says is, of those who tested positive, how many truly had the disease? Not of those who have the disease, how many tested positive? And I know that sounds very confusing, but when you think about it, this is a much better measure of how useful something is, okay? The negative version, the negative positive predictive value, represents the probability of being disease-free if you were tested with a negative result, okay? If you got a negative result. So that is, of those that tested positive, how many did we get right? And of those that tested negative, how many did we get right? That's what it actually tells us. So conditional on a particular test result, how many had the disease if they tested positive, how many didn't have the disease if they tested negative. Okay, so I'm going to give you some really ugly formula for it, because it does actually, there's 2 points I want to make here, but it's also got a very simple formula as well. And I'm going to really talk about that when we calculate it, because it's much more intuitive. But there's 2 points I want to make. First is we can use Bayes' theorem. It is a posterior probability, and if you know anything about Bayesian statistics, you will know that it uses prior knowledge to calculate probabilities, okay? And that prior knowledge in this case is the prevalence of the disease, the probability of having the disease, which is prevalence, okay? So you can see it right there in the formula, okay? In the negative value, we have the complement of prevalence. So we could say the prevalence of not being diseased, okay, which is right there in the formula. Now, the reason I want to make this point is the predictive values depend on prevalence, okay? So how high or lower predictive value can be is very strongly related to how prevalent the disease is. So we've got to take that into account when we assess a test in terms of its positive predictive value and negative predictive value, okay? So for example, if we've got very low prevalence, a positive predictive value often looks terrible, okay? It looks terrible. It isn't necessarily terrible, but it looks terrible. Okay, now let's talk about the very simple way of calculating them. Now, just again, note that these two things have been transposed. So the probability of having the disease given you've tested positive. So of those that tested positive, how many had the disease, okay? How do we calculate that? We calculate the true positives over everyone who got the positives. Now, going back to that table right at the start, we are no longer using the row totals, we're using the column totals. So it's those that tested positive over everyone who got a positive result. Okay, not those who tested positive out of everyone who had the disease. So it's a little bit different. So, okay, so let's go through an example. Sorry, I just wanted to make this point. I've already really made it. I sort of went ahead and stole my own thunder, and that is, I mentioned that the positive and negative predictive values are very susceptible to the level of disease prevalence, and we have to take that into account when we're presented with positive and negative predictive values, because they can look much worse or much better than what they are just based on how rare or common a disease is. Okay, so let's go through an example. Here, our positive predictive value is the number of people who tested positive, the number of people who were correctly tested positive, and they really have the disease, over all people who tested positive. So 90 over 290. So our positive predictive value was about 31%. Okay, that looks not very good. It doesn't look very good at all. Okay, the negative predictive value is of the people that tested negative, how many people were true negative. So it's 800 over 810, which looks really good. But as I said to you, this is rather artificial. This looks really good simply because the prevalence is only about 9% in this population. 100 out of 1,100 people had the disease, only about 9%. And so our positive predictive value looks not that good simply because of that. Okay? All right. But it does tell us how useful. So it's what it's saying is out of the 290 people I said had the disease, only 90 of them actually had it. All right, so it really is about the usefulness. Of the 810 I said didn't have the disease, I got it right a large majority of the time. All right, which is, 800 out of 810. So that's utility. Okay, so really, again, I'm going ahead of myself today. Okay, so even though the test was quite sensitive and quite specific, the positive predictive value was not that high. So what that really means is of those that tested with the disease, only about 3 out of every 10 actually had the disease. In this case, the positive predictive value was not that high because of the low prevalence, but it's also, alternatively, I should say conversely, it also meant that the negative predictive value was actually quite good simply because of the quite low prevalence, okay? Personally, I don't really like predictive values that much. I think there is a better way of talking about the utility of the test, and that's what we're going to go into now. But it doesn't really matter what I think because it's a value that's expected when you present statistics for a diagnostic test evaluation. We generally have to present them. What I would say is just take them with a, basically with a grain of salt. Okay. So now let's talk about the likelihood ratios, and these are much better. I love the way these work. They make a lot of sense, and I know a lot of people use them without actually realizing what they are, and particularly the positive likelihood ratio. I think it's a really intuitive measure when you think about it. Okay, so let's think about this, and it brings this idea of posterior probability in as well, in a very sensible sort of way. So when we can conduct a diagnostic test, we are trying to rule somebody in with the disease or rule them out without the disease. What we could do, if we were very simplistic, is really just say, well, 10% have the disease, so you've got a 10% chance of the disease. We don't look at anything about you as a patient. We just assumed a 10% probability of the disease. So the idea of disease likelihood is, oh, sorry, I'm just going to have to close that down. I'll just turn that off. Sorry about that. So what this really means is if I do not take anything about you into account, I don't take I don't do any blood work, I don't look at your height, your gender, anything like that. If I know nothing about you whatsoever, the chance you have the disease is 9%, just as the example I used. So what we want to know here is if you do give me this additional information, so for example, a couple of biomarkers, can I improve my probability of saying you as an individual, you as a phenotype, for example, have the disease? So how much additional information does taking these measurements on you give me? Does it shift my confidence in you having the disease or confidence in you not having the disease? Either way, does it balance the scales? And I think that's a really nice way of thinking about it. Okay, so the pre-test probability that you have the disease is just disease prevalence, 9%. Okay, when we conduct a diagnostic test using patient-specific information, can we shift this probability one way or another? Okay, to get a post-test probability that changes from 9%. So likelihood ratios tell us how much we would shift our suspicion based on your test result and say, actually, we're much more confident than 9% that you have the disease, or no, you're much less likely than 9% to have the disease, okay? And the first of those, if it shifts you in the positive direction, is what's called the positive likelihood ratio. And the shift in the other direction is actually called the negative likelihood ratio. Okay, so probably the best way of doing this is going through an example, but the concept is a very nice one and it makes a lot of sense for it. In fact, if you can understand it, you can understand the whole premise of Bayesian statistics in the first place. Okay, so as diagnostic tests can give us two possible results, a positive or a negative, there are two of these likelihood ratio tests. There's a positive likelihood ratio, LR with a little plus next to it, and a negative version, okay, which is an LR with a little minus. And just remember, the pre-test probability, prevalence, is based purely on the population, not on your patient-specific information. Whereas a post-test probability also includes the information from the diagnostic test, as represented by a bunch of biomarkers or your gender or race or whatever might tell us something about whether you're likely to have the disease. So LR ratios use the extra information on top of pre-test probability that a test gives us to calculate these positive and negative likelihood ratios. Okay, so let's talk about the first one, and this is the one I really like. It's sort of much more intuitive. Now, and I don't particularly like this formula. The reason I give you this formula, it's a very simple way of actually calculating the likelihood ratio. But here, this makes a lot more sense with me. So the positive likelihood ratio is the probability an individual with the disease tests positive, okay, so sensitivity, over the probability of an individual without the disease testing positive. So in other words, it's an odds. It's a measurement of odds. The probability that you have a positive test and you have the disease over the probability you have a positive test and you don't have the disease. So true positives over false positives, in other words. The negative likelihood ratio is the probability an individual with the disease gets negative. So that's a false negative over a true negative, which is the probability an individual without the disease tests negative. Now, I'll come back to these and talk about them in a lot of detail when we talk about the diagnostic odds ratio. But let's go through an example here, and it's all very quite simple. Calculating from the table, we could just, the simplest way of actually calculating, we can actually use the numbers here too, but the simplest way of doing it is pointing out that 90% of people were true positives. Okay, so of those that had the disease, 90 were true positives over the false positives, which is 1 minus 0.8, okay, which was the 200 out of 1,000. So what this means is 4.5 times the number of people, sorry, I'm going to have to rephrase that, okay? In terms of odds, the odds of getting a positive test and having the disease is 4.5 times higher than getting a positive result if you didn't have the disease. Now, just note I mentioned odds there, not probability. Okay, the negative likelihood ratio is this false negatives over the true negatives, okay? Which in this case was 0.13. Now, what do these weird numbers mean? Because they're not that intuitive unless you're willing to really do the hard work and think very hard about them. How most clinicians use likelihood ratios is they sort of forget what they mean. I guess that's not the worst thing in the world. And they tend to use guidelines about what is a good, like a positive likelihood ratio, and what is a bad a bad likelihood ratio. So in our cases, we have LR plus equals 4.5 and LR minus equals 0.14. So again, remember, they represent a sliding scale of disease probability. And they're also stable, okay? They're not going to worry too much about disease prevalence, unlike the positive and negative predictive values. And the way they are used, as I said, most commonly by clinicians is we have this table and we say, well, if the positive likelihood ratio is this, then it is a good test. They're cut points, in other words. And if the negative likelihood ratio is below this, it's a good test. And that's fine. I don't really mind that people actually use it like that, but it is nice to know what they mean, okay? So let's look at this table. Generally speaking, if we have a likelihood ratio of 1, regardless of whether it is positive or negative likelihood ratio, it is uninformative. In other words, if the diagnostic test tells us absolutely nothing, the probability you have the disease stays at 9%. That would mean a likelihood ratio of 1, whether it be positive or negative. If it is a positive likelihood ratio, we want it to be up this end right here. The general rule is if your likelihood ratio is above 10, then your diagnostic test is very informative for patients who have the disease, okay? And that's how people will use it. If they get a likelihood ratio, positive likelihood ratio above 10, they are very, very happy because it is very good at ruling people in, of telling us whether they have the disease. On the other end of the scale with likelihood ratio negatives, we want it actually to be less than 1, and the closer it is to 0, the better a test is at ruling people out, okay? So how did our test do? Okay, our likelihood ratio positive was 4.5, so it was at the upper end here. We could say it's a small increase in the likelihood you've got the disease. I think that's probably being a bit mean. It was so close to 5 that I'd probably call it closer to a moderate increase. In other words, for patients that really have the disease, our test was relatively informative, okay? Collecting this information is worth it. Okay, for the negative 0.13, it's in this zone. So it gave us a moderate increase in our ability to rule out patients without the disease. So in summary here, likelihood ratios tell us how much more information our diagnostic test gives us above just using the pretest probability, which is prevalence itself. In other words, which is not patient-specific at all. Does using our patient-specific information tell us more about you've got the disease, that's likelihood ratio plus, or not, don't have the disease, that's likelihood ratio minus. So is our test useful? I think it is. I think it is here, particularly because, that one said yes, it's a moderate decrease in the likelihood of the ratio, so it's better at ruling someone out. And I think to say that it's a small increase, given it's so close to 5, I'd probably push it more up into this category. But these are the cutoffs that a lot of people use, all right? And if you want to use it like that, that's fine, but it's nice to think about how it works. And this notion of using this patient-specific information, did it really push my decision one way or the other? Ruling in, ruling out. Okay. Now, let's talk about ROC curves. Often, many new diagnostic tests are based on a continuous scale, okay? So particularly with biomarkers, we get this continuous measure, and also a lot of time it's a biomarker we don't understand that well, okay? So we have this new continuous scale, and we want to decide at what point should we put a cut in that scale and say, if you're above this level, you have the disease. If you're below this level, you don't have the disease, or vice versa, if it's the other way around. Okay, and we want to know where that optimal cut point in our continuous scale is. Okay, now, if we're using a continuous variable, we can't use a 2x2 table. We don't know where to put our cut point. We only know whether you've got the disease or not, according to the gold standard. We don't know where to put this. Now, we should also note here, now I'm assuming we're talking about a biomarker which high values are bad and low values are good. It could be the other way around. But the point is here is sometimes sensitivity and specificity don't have the same benefit. So maybe identifying someone with positive is much more important. So having higher true positives is much more important than and we will allow false positives into our test. And the easiest way to that is to shut your eyes and say everybody has the disease. 100% sensitivity. The specificity of that test will go down terribly. If I just close my eyes and say everybody has the disease, everybody has COVID, for example, it's going to be 100% sensitive. I will capture everyone that has COVID, but I'm also going to capture a lot of false positives as well, saying they're positives when they're truly not, okay? So I can increase sensitivity at the cost of specificity, and I can increase specificity at the cost of sensitivity, if I choose to, by making higher or decreasing where that cut point is. Okay? So we really do need a way of assessing this balance of sensitivity and specificity. Now, by the way, sometimes we can increase sensitivity with a lower cost to specificity. Okay, so it's not a one-for-one sacrifice. Okay, and I'll talk about that in a minute. Okay, so how do we actually decide where this balance should be? We can use receiver operator characteristics curves, also called ROC curves, and really that's what they are. And this is a horrible name for these things. It comes from early radar technology. That's where the name comes from. So I would just forget it and call them ROC curves, because receiver operator characteristic curves, that doesn't mean anything. Well, it's not meaningful to us at all. Okay, so I just want you to note that ROC curves, all they really do is explore the balance between sensitivity and specificity as we move the threshold around, okay? And what I'll do is I'll come back to this in a minute. I just want to mention two other statistics very briefly before I do, because they're very closely related to ROC curves, and particularly this one, Yoden's index, which is a way of deciding where that cutoff should be, okay? So what we can do is actually plot this thing called Yoden's index, and it will say, here's the perfect cut point, assuming that sense and spec are equally important to you, all right? Diagnostic odds ratios are actually a useful statistic too. Really what they are is the ratio of the positive to negative likelihood ratios, but you do have to think about what they represent. And I know this stuff's probably going in one ear and going out the other. What you probably should do is come back and just read these notes or other resources on the internet about what these things represent. They really do make a lot of sense, but you need to think about them 3 or 4 times first, okay? Also, I'll point out that theoretically these two measures don't depend on prevalence. So providing the definition doesn't change of the disease, okay, which from paper to paper to paper how people define a disease may actually change. But if that does not change, then both diagnostic odds ratios and Yoden's index have meaning across different studies. That's why people like diagnostic odds ratios, because it's comparable across studies. Okay, so let's talk about, very briefly, Yoden's index, one of the oldest measures of diagnostic accuracy. It's been around for ages. And what is it? The Yoden index is the sensitivity plus the specificity minus 1. Okay, now think about it like this. If the sensitivity was 0.5 and the specificity was 0.5, Yoden's index would be 0. And that means a totally uninformative test. Whereas if sensitivity and specificity were perfect, they were 1, so that would be 2, in other words, then we would have a Yoden index of 1, which means that sense and spec are perfect. The test is 100% accurate. Okay? So in other words, the Yoden's index is a nice measure of discrimination between diseased and non-diseased patients. The one thing that's a problem with it is it doesn't actually tell us anything about the balance of sense and spec. And we know that false positives and false negatives have different costs a lot of the time. Telling people they have the disease when they really don't might be better than telling people they don't have the disease when they really do. And sometimes that switches around the other way. Okay, so what do I mean by that? A test with sensitivity of 0.99 and specificity of 0.61 yields exactly the same Yoden's index of 0.6 as a test with sensitivity of 0.8 and specificity of 0.8. So it doesn't really tell us much about this balance. It's an overall measure. Think of it as an average measure in that respect. I personally don't use it for this purpose. I don't think it's a useful index to talk about across different studies. Where it is useful is deciding where the cut point should be on an ROC curve. Okay, and that's its real use. Okay, and we'll come back to that. Okay, so the other measure is the diagnostic odds ratio. And again, this is a very useful measure to compare different studies. So if you were going to do a systematic review of diagnostic accuracy of tests for a particular disease in particular population or a particular target population, this is actually a very good measure to use. So, for example, if we do meta-analyses of diagnostic test studies, we'll often use the diagnostic odds ratio. Okay, what does it represent? There are about 10 billion different ways of actually calculating it. Here is the most useful. So as I mentioned before, a likelihood ratio plus is a measure of odds, okay? And a likelihood ratio minus is a measure of odds. So the diagnostic odds ratio is the ratio of these two odds, okay? But what does it actually tell us? I mean, I've told you how to calculate it now, but what does it tell us? It tells us how many times higher is the odds of a positive diagnosis in those with the disease relative to those without the disease, okay? So if you've got the disease, how many more times likely am I to say you have the disease over me saying you have the disease if you truly don't? Okay, so a very high diagnostic odds ratio is a good thing. Also, I should mention, now this is sort of a bit silly in some respects because this almost never happens. It's not going to be defined if the sensitivity or specificity is perfect because we're going to have zero denominators. Okay, so I should just mention that on the way past, but that really is quite rare. Okay, so now, after all of these measures, and I know they're probably whirling around your head, let's go through an example because that will really hopefully contextualize these for you. So fever in children, sorry, that's a typo. Fever in children in a majority of cases is a result of a self-limiting viral infection, a cold, a flu, so on. But some of these children will have a bacterial infection, which can progress to a quite serious condition. Okay, despite many studies having been done, the management of febrile children still persists for treating physicians. For example, the consequence of not treating a child who has a bacterial infection is potentially life-threatening. So false negatives are bad. But also we know that there's an overuse of antibiotics, and we know antibiotics don't do anything for viral infections at all. So false positives are bad too. Okay, even though you could probably argue this is not as bad as missing the disease. At least at the individual patient level. From an epidemiological perspective, you might actually say this is really, really bad because overuse of antibiotics is generally bad. So a number of clinical measures were trialled to distinguish between bacteremic and, excuse me, non-bacteremic febrile children. We'll consider two: white blood cell count and temperature. Okay? So now we've got two diagnostic tests, and we're actually going to say which of these is better. Okay, so here is this ROC curve I've been talking about. All right, now the first thing I want to say about it is remember, this is for a continuous measure, okay, in this case, white blood cell count. So an ROC curve is simply the plot of sensitivity against specificity, or more to the point, 1 minus specificity, which is true positives over against false positives for different cutoffs of white blood cell count. Now, according to this, and using Yoden's index, the best cutoff, which gives us the best balance of sensitivity and specificity, is 17.9. We get the sense, we get the spec, we get our positive and negative predictive values, we get our positive likelihood ratio, our negative likelihood ratio, and the thing that we often talk about with ROC curves is this area under this curve. So basically we work out how much this area is here. I'll talk about that in a minute. Okay, so how would I interpret this? How would I write it up? If we use a white blood cell count cutoff of 17.9, which was the first value here, we would expect to correctly identify 74.4% of children that do have a bacterial infection, which is a sensitivity, and correctly exclude 75% of non-bacteremic children, which was specificity. And just note that optimal cutoff was obtained using Yoden's index. Okay, so it was calculated for every value, for every cutoff, and we picked the best one, which is sensitivity plus specificity minus 1. Which you could work out very easily from this. It was about, what is that, 74, yeah. What are we talking about there? It was about 0.49 or 48 or something like that. Okay, so the probability of a child testing positive and really being bacteremic is 0.078, which is not that good. What this really means is of the children that had a positive test, only 7.8% of them actually had a bacterial infection, as opposed to the probability of a child testing negative and not having the condition. So of those that we called negative, 99% didn't actually have the disease, which is very good. Now, we also know that these two values here are very dependent on prevalence, okay? So again, I'd always take them with a grain of salt. Talking about the likelihood ratio, 2.98 suggests that a positive test only slightly increases the chance of having the disease. In other words, what is this white blood cell count? taking somebody's white blood cell count will rule somebody in to some extent, okay, than just closing our eyes and saying, you have the disease, you don't have the disease, all right? So how informative is white blood cell count in telling us someone has the disease? It's 2.98, and how would I work out whether that's good or not? I can just go to my guidelines. There it is. So what was it? 2 point something? I can't even remember. It's a small increase in the likelihood of the disease. Okay, the likelihood ratio minus was 0.34. Again, it's only a small increase in the probability of ruling somebody out. Now, I have the likelihood ratio plus and the likelihood ratio minus now, so I can calculate the diagnostic odds ratio. There it is here. So the odds of a positive test is 8.76 times higher. The odds, not probability, is 8.76 times higher in children with a bacterial infection relative to those without a bacterial infection, which is not bad. It's not too bad, okay? So in other words, it's relatively informative. One that has a diagnostic odds ratio of 1 doesn't tell us anything. The area under the ROC curve is 0.755, shows that white blood cell count as a tool, not this particular cutoff, but as a tool overall, is reasonably effective at discriminating between those with and without a bacterial infection. Now, I do want to make a point here, and this is where I disagree with general practice when it comes to this. People think that the ROC is the most important measure when looking at diagnostic tests. I think if you are looking at a bunch of biomarkers and you want to compare them, fine, I agree with you. ROC is quite important, but it actually doesn't tell you too much about how useful a diagnostic test is. So a lot of people think the area under the ROC curve is the #1 statistic you should present. They'll do their sample size calculations based on it. I don't agree in most applications. I think sensitivity and specificity is where we should really focus if we only have 1 or 2 diagnostic tests that we're doing. And I think what needs to be done, because there's no guidelines in this area really, is you've got a little bit of a fight between the biomedical types at this point in time, where they're much more about novel tests and having lots of them, high throughput sequencing technologies and so on. So they may have 20, 30, 40, 5,000 biomarkers, and they want to compare those, as opposed to a clinical setting where we might have 3 or 4 measures that we'll combine together to give us a diagnostic test. I don't think ROC is a particularly important measure in that case, because we don't care about the whole scale. We care about our cutoff and how sensitive and specific a disease is. So I think there's a lot of confusion out there about the relative importance of these measures. I think it's going to change with setting. I think if you're in a much more preclinical, exploratory type setting, ROC is fine. If you're much more into confirmatory diagnostic testing, I think the other statistics are much more important where we have a particular cutoff. I just wanted to make that point because there's a lot of confusion out there about it. Okay, so the area under the ROC, I should just mention that too, because this is the measure that people do present with ROC curves. As indicated above, the area under curve tells us about a clinical measure's ability, independent of its particular cutoff, to discriminate between those with and without the disease. So it is an overall measure of accuracy for an overall measure. It's not the cutoff. And an area that's under the curve that's closer to 1 means we've got better. This biomarker's ability to discriminate is better, whereas 1 closer to 0.5 is worse. And 0.5 is like flipping a coin. Okay, if we had prevalence of 50%, 0.5 is essentially like you walking into my clinic, me flipping a coin and saying, yep, your heads, you've got the disease. All right. Okay, now let's look at a not so successful diagnostic test. Here it is. We're going to use temperature here. We'll use a cutoff of 38.2 degrees Celsius to say, yes, you have. No, you haven't got a bacterial infection. It's got great sensitivity, okay? It's not bad, but it's got terrible specificity. Okay, so what that means is there's a lot of false positives going in here. All right? Our positive predictive value, and that's the positive predictive value tells us. What it's saying is out of all of the people we said were positive, actually only 3.3% of them really had the disease. Okay? The negative predictive value was 98.9. Our likelihood ratio of 1.2, which is terrible, it's close to 1. It means don't even bother telling me your temperature because that's not going to tell me whether you have the disease or not, or whether you have the disease. Okay, 0.4 is a little bit better, and the area under the curve was close to 0.5. It's terrible, basically. Okay, again, the interpretation, straight away from the shape of the ROC, we can just say, no, forget about it. Okay, I mean, really, that's all I would look at. I wouldn't even bother looking at the other statistics here. But just to very quickly go through, Yoden's index said 38.2 was the optimal cut point for temperature. And we can see that the test is quite sensitive, but that was because we threw a lot of false positives in there. Okay, we basically said everyone's got the disease. Okay? So in sharp contrast, only 0.5% of bacteria-free children tested negative. So in other words, the specificity was terrible, and it was lots of false positives that caused that. Of those that tested positive, only 3.3% actually had the disease, but of those tested negative, about 99% were disease-free. Okay, and we can see that a positive test doesn't change our confidence in you having the disease or not. All right, the diagnostic odds ratio was 3, and that's the technical term, it's terrible. All right. So here's the question for you quickly that I just want to think. For both white blood cell count and temperature diagnostic tests, the positive predictive value was low and the negative predictive value was high. What might explain this? I'll give you the answer. I don't expect you to answer. Low prevalence. That's what it was, okay? So these two measures are very susceptible to prevalence, okay? And they're going to change a lot across studies because the prevalence might change quite a bit across studies too. So I would present them, but I wouldn't actually use them too much. You have to present them because that's convention that you present them, but they're actually not very good measures unless you're really taking into account your population and talking to other people who understand your population very, very well. If you take white blood cell count to be the better test, which you should in this case by far, are you happy with the optimal threshold? Now remember, that optimal threshold using Yoden's index considers sense and spec to be equally important. Don't forget, we can actually shift that. We can shift that further up this way to increase sensitivity, but you can see the false positive ratio is actually going up as we do so. All right, and we know false positives were bad enough already in this particular test. So probably I would keep it as is, but don't forget, letting someone diseased go home and keeping someone non-diseased for further testing or whatever, you got to think about the relative cost of those things. All right. So I really just wanted to mention that the way we can define this optimal cutoff, assuming they're equal, there are two different measures, but they often give us the same result anyway. Yoden's index is the first one where we just essentially find the maximal Yoden's index. And the second is a measure called Dmax, which essentially represents the point on the curve that is closest to this top left corner. That's all Dmax is. And you can see that that's that value there. So in this case, both Yoden's and Dmax gave us exactly the same value. All right. So I should just also mention quickly that the shape of an ROC curve tells us straight away whether something is good. If we get this nice bulged convex shape, that's an informative ROC curve. But if we get a straight line like that, it's terrible. And you can see that with our two examples. This one was bulged and convex, which is good, okay? So in other words, it departs from this straight line right here, which is an uninformative test, whereas with temperature, it was pretty much along that straight line. It was terrible, okay? Absolutely terrible. So that shape does tell you a lot about whether your test is good. All right, yeah, there you go. So here we can see white blood cell count looks a lot better than temperature. Not just from the shape of the ROC curves, but almost every diagnostic accuracy statistic that it's spat out at us tells us that temperature is terrible and white blood cells not bad. Okay, so if we were going to report this, say we wrote this up in a paper, these two diagnostic tests, there are generally 8 measures that we should provide for each test that we do. And the most important are sensitivity and specificity. We can give the overall accuracy if we like, but sensitivity and specificity, really, they are clearly the most important. Again, 3 and 4, the positive and negative predictive values, we present by convention. I would personally don't talk about them much because I just think they're so study specific and so population specific that they're not really useful. And also they're used in other measures anyway. These calculations are used elsewhere in a much more informative way. So the positive and negative likelihood ratios and the diagnostic odds ratio and the area under the ROC curve. The relative importance of the area under the ROC curve changes with the type of study. If we've got lots of biomarkers, it's a preclinical or translational study, much more biomedical. ROC is a much more important measure. If you're talking about in a clinical setting where the biomarkers are relatively well established or clinical measures are relatively well established and you want to combine them into a diagnostic test, I don't think ROC curve is terribly important. I think these other statistics are much more important. Okay. Also, I would point out that there are reporting guidelines. So while there's no convention that talks about how good or bad these relative measures are across different types of study types, there are reporting guidelines, and these are called STARD and or tripod are the two sets that are very good. The tripod guidelines are much better if we've got a multivariable diagnostic test. Okay, so you're combining 4 or 5 clinical measures together or 4 or 5 biomarkers together into a single diagnostic test. Tripod's a better one. STARD was the original one, and you can find those on the Equator Network where you can find Consort and Strobe and all of those. Are you guys familiar with that? The reporting guidelines? Consort, Strobe, STARD, Tripod, those sorts of things. Very useful resource. I mean, if I was ever writing up papers, originally when I was writing up papers, when I was first doing it, I would always go to them. I mean, everyone sort of knows Consort, but Strobe is a very good one for observational studies. Okay, I want to very quickly talk about sample size. I really don't want to talk about it in much detail at all. In fact, I'm hoping that you did attend the first lecture, so you're familiar with these types of formulas, because really it's almost exactly the same. Okay. In fact, you could argue that it's really just an adaptation of one that we've already covered, which is a test of proportions. Okay, so if I was going to power my study, I shouldn't say power because we're not necessarily doing a hypothesis test. If I was going to do a sample size calculation, usually I would use sense or spec or both to do my sample size calculation. But some people, again, they use ROC, area under the curve, as their primary outcome, and that's a totally different measure, and I'm not going to talk about that at all. Okay, so I'm going to talk about calculating our sample size using sensitivity or using specificity. Just note that there are two different types of sample size calculations that we tend to do. The first, and this is the one I most commonly do, and that is the precision of an estimate. In other words, we're not comparing two different diagnostic tests. And by the way, I don't include the gold standard in that. So I'm not saying this new diagnostic test is better than that new diagnostic test. I'm just saying, here's my new diagnostic test and here's the 95% confidence interval for sensitivity or specificity. That's a precision calculation. As opposed to when I do want to compare two new diagnostic tests, which that is a power calculation because it's a hypothesis test involved. I'm actually only going to cover the first one today, but really this is a straight test of proportions problem. But there is just something very, very important to remember. So the first case is a precision calculation. Note that there's no beta, there's no power that comes into this because there's no hypothesis being tested. So here is our calculation there. We get the quantile from the normal distribution for our 95% confidence interval, and I calculate the variance of my measure, whether it be sense or spec, and I divide over my level of precision. So how wide my error margin, in other words. We'll go through a very, very quick example. Here is the second case where I want to compare two different tests. So we can see beta, power comes into it, and I'm giving you the definitions. I am assuming that you did come to my sample size lecture. I really do want to skim past this because it really, to do it justice, I probably need to spend 10 or 15 minutes on it. Okay, but I just want to mention one thing here. There is a little problem with this formula. If I wanted to calculate the number of people for a particular sensitivity, are all of my, I shouldn't say patients, are all of my participants included in that formula? Who is included in the calculation of sensitivity? Isn't it going to only be people with the disease? Because people without the disease don't come into sensitivity. They don't come into it at all. Okay, so this doesn't tell me the number of people I need. It tells me the number of diseased people I need. Okay, so that's actually very important to note that. I don't want to go underestimating my sample size. That's a big sin. So in other words, it tells me the number of cases I need, not the number of participants, okay? If I want to work out the number of participants I need to bring the prevalence into the formula, and that will actually increase the sample size to get that. So I really just wanted to make that very important point. In the lecture notes, I give you a worked example, but I'm really not going to go through this because I just don't have the time for it, okay? So just look through the lecture notes and see that example. But that is just very important that you realize that this formula only gives us the number of cases, not the number of patients, and we need to bring the prevalence of the study into account. Similarly, we can actually do exactly the same thing if specificity is our primary statistic that we want to. And then in the denominator, we bring in 1 minus prevalence. So the prevalence of healthiness, if you like. All right? Okay, so I'm not going to go through an example. There it is there, and I'll just allow you to work through that for yourself. The last thing I want to do, we're nearly there, is talk about the design that is often used for diagnostic test evaluations. There are two main approaches. The first approach is a cross-sectional or cohort design. Okay, in this design, we enroll participants as they would normally show up to our clinic. And then, so if we're talking about a diagnostic test, you know, as patients walk through our door, they're symptomatic, and we send them off to be tested, okay? Both with our novel test and with the gold standard, okay? The advantage of this approach, of course, is generalizability, because our sample, the people who walk through our doors, should be relatively representative of people that walk through other clinics, similar clinic stores, if they're similar population. So these results are much more generalizable, okay? Particularly with some of our statistics. Some of our statistics, prevalence doesn't matter. Others, particularly the positive and negative predictive values, prevalence matters so much, okay? So it has the advantage of generalizability. Participants are more likely to be a representative sample of our target population, so the results in our study likely to better reflect what we see when we deploy the test. So in other words, there's a higher chance of external validity. All right? The disadvantage of this cross-sectional or cohort design approach is it's inefficient and costly. If our disease is rare, we may need a very large sample overall to get sufficient cases, okay? This is exactly the same principle as when we do a standard cross-sectional study or standard cohort study versus a case control study. If we've got only 1 in 10,000 people who have the disease, then in order to get 50 or 60 people with the disease, which our sample size requires, we're going to need 600,000 people or something like that enrolled, which is a very costly study. So the other approach is a case control type design. Here we estimate the number of cases we need. So we might need 50, 60, 70 cases. And then we enroll from 1 to 4 times as many controls. After you have 4 times as many controls, there's no point to enrolling extra controls. It does nothing for you, okay? And that's well known for people who do case control studies. We never match more than 4 controls to 1 case. It's pointless, okay? It doesn't increase power, okay? So greater than 4 times the number of controls does not improve statistical power. So we then administer our new diagnostic test on each. Now here, we have to know the gold standard already, because gold standard tells us whether someone's a case or a control, okay? We need to know whether they truly have the disease or not. So we already know their true result, but we will then administer our diagnostic test on these cases and controls, okay? So what's the advantage of this is money, ethics, and sampling effort. So particularly if a test is invasive, we don't want to test people unnecessarily. It's also going to be a lot cheaper and a lot less effort on our part to get. So in other words, we might need 200 people as opposed to 200,000 people. It really is a much more efficient design. However, the disadvantage, and this is the disadvantage of case control studies as a general rule, is that they might represent a biased sample. So just note that sample prevalence in a case control study is purely artificial. We decide on what the disease prevalence is. It can be 50-50, so 1 case to 1 control, or it can be 20%, where it could be 1 case to 4 controls. But that is not true disease prevalence. It's an artifact of our study design, okay? That's not such a big issue with diagnostic test evaluations, but note it's going to be a big issue with the positive and negative predictive values, which are arbitrary. If I did a case control study, I would say I am not going to present positive and negative predictive values because I do not want to mislead you. And then a reviewer would say, where are the positive and negative predictive values? I would turn over and then present them, okay, even though they're stupid. And really, that's life with dealing with reviewers. Actually, I wouldn't do that. I'd argue a bit first, but yeah. Okay, so just what I would say is if you're going to use a case control study, the positive and negative predictive values are just silly values. They don't mean anything whatsoever. Okay, so the last slide, I think this is it, yeah. Diagnostic tests sorry, I've got the odd typo on here. Diagnostic tests attempt to predict the disease membership of individual patients based on their clinical characteristics. So it's very important. Before we do this, all we know is disease prevalence. So if a disease prevalence is 20%, you've got a 20% chance of having the disease if I don't know anything about you. Okay, now we need to understand that this is a predictive study. It's actually not an exploratory study. It's not a hypothesis testing study. It's predictive. It's about individual patients. So what I mean, why I'm making that point, is something can be a risk factor for a disease, but we would not use it as a diagnostic test. So it's well established that BMI is a major risk factor for type 2 diabetes, but BMI is a terrible diagnostic indicator. Okay, we would not just measure someone's BMI and say you're likely to have diabetes or not. So its likelihood ratio values would be very close to 1, BMI. We want to know how much more information a diagnostic test tells us, and it's got to be very high. Okay, so in that respect, it's not a hypothesis testing study, it's a predictive study. These relationships need to be tight. Okay, that's what I mean by that. So we have much higher standards than simply saying, oh, yeah, this is a risk factor, okay, which can be a much weaker association. Routinely, if you're following best practice, what we should do is come up with a diagnostic test using a training sample and then apply that to a held out sample. Okay, now, as I said before, the guidelines around diagnostic test evaluations are very loose at the moment. Someone needs to write a really good paper, a set of guidelines that people need to follow, but for some reason that hasn't been forthcoming. Okay, by the way, you would be cited millions of times if you could actually successfully do it. You would. People would just cite you left, right, and centre. So ideally, we want to establish our diagnostic indicators in our training sample and then validate them using a holdout or test sample to establish external validity. In other words, generalizability. In fact, the best type of study is one where we collect the sample, come up with the diagnostic test, independently then go and collect another sample under slightly different conditions, and then actually show that it works. That's the best type of study. So some areas already sort of require this, like a lot of the omics type journals are starting to get a little bit pushier about that, but a lot of clinical journals aren't at all. They're not even mentioning it, which is sort of funny. I would have figured it would be the other way around as a general rule, but they're not asking for holdout samples at all. People get their 500 patients, they do their diagnostic test, they present sense and spec and all of these things, and that's it. Your paper gets accepted. No one's actually saying, well, wait a sec, these are the same patients that you used to come up with the test. You can't do that. That's going to be biased. It's going to make it look better than what it really is. But anyway, it is likely in the future that reviewers and journals are going to get a little bit pushier with this. And anyway, we want to do the best work. So yeah, I would suggest that, you know, following some sort of guidelines. STARD and tripod are a good start because they talk about what you should report. Okay, thank you. Any questions? Sure. Just one at a time, actually. 2 reasons I will forget it, and 1 so I can actually repeat it as you say it. Okay?
And the first question is, if we don't use the golden standard, we just compare 2 methods, 2 diagnostic tests, can we use the term like sensitivity?
No, we can't. And that's a very, very good question. So, sorry, the question was, if we just use 2 diagnostic tests, but we don't have a gold standard, can we use the words sensitivity and specificity? No, we can't, because we don't know true positives and true negatives. Okay, and if we don't know true positives and true negatives, we can't say sensitive and specific. In fact, you shouldn't use any of those statistics that I presented today. If you have 2 diagnostic tests and we don't know the gold standard, we can only talk about when they agree and when they don't agree. We can't talk about when they're right and when they're wrong. Okay? Okay, so that's a reliability study. It's just like getting 2 raters. It's exactly the same problem. And, you know, you'd go much like a kappa statistic is probably where you'd go with that type of thing. All right?
And the second question is, in your slide, you started the disease of prevalence and absence.
Right.
But if in case there's like severe disease, mild disease, and absence, I know this, if we're analyzing this kind of data, it's like quite related to the exact kind of
Right, okay.
Yeah, is there a general analysis?
There are methods, but again, we have to move away. Now, what you could do then, and this is not necessarily the best thing to do, but what you can do is compare in a pairwise fashion. So let's say we have moderate and severe and absent. So you can compare moderate to absent and severe to absent and get sensitivity and specificity that way. Or you can actually do it. Now, again, we've got to realize what's our gold standard. Is our gold standard present and absent? And then our diagnostic test is absent, moderate, severe, or is it a 3x3 table? Okay, so sorry, did I repeat that question for you? It was basically if we have more than 2 categories, not just present and absent, we may have absent, moderate, severe. Okay, so there's 2 issues there. What's our gold standard? Is it present absent or is it the same? Now, the fact is if it's the same, it's probably not using the same cutoffs for what we call moderate and severe. So even the 3x3 table might be a little bit misleading. I've actually come across that problem before and how to present it. And strangely, again, I would go with something like a weighted kappa statistic, where we talk much more about agreement. But then if the gold standard says present absence, I might also do the pairwise sense and spec thing. So moderate versus absent and severe versus absent. So it's one of those things which is not satisfactory, but what I would use is multiple approaches. It's almost like being a lawyer and trying to present a case for a new novel test using multiple methods to try and convince the reader of it. Okay? Yeah, but I have actually come across cases like that where we've had these multi-categorical things and they've just been totally different types of measures too. You know, so one might be pathology, but one might be, you know, some other total different biomarker. So is there a such thing as moderate disease according to this novel biomarker? Or do we just split it into 3 categories? Are those 3 categories likely to align with what a pathologist says? Probably not. So yeah, it's a very difficult issue to deal with, yeah. And my approach in those situations is always use multiple approaches. And a lot of the time I won't even use all of those approaches in the paper. I will pick out the ones that are most convincing, providing they're sort of valid. I'm not going to try and mislead people, but that's how I would do it, yeah. All right? Okay, but that's a good question too. That's a tough one. Okay, thanks. Any other questions? No? Okay, thanks. That's the last one.